from Vet Triage. This will be published on February 4th, 2025. And we are going through this issue of veterinary surgery from April 2022. And a fun one, incidence of and risk factors for surgical site infection following canine limb amputation. This comes out of the the College of Veterinary Medicine in Georgia and College of Veterinary Medicine, Texas A&M. The objective: to determine the incidence of and risk factors for surgical site infection following thoracic and pelvic limb amputations in dogs, 248 dogs. Results: the incidence of surgical site infection was 12.5% for all procedures and 12.9% for clean procedures. We will define what that means in a minute. Factors increasing odds of infection were muscle transection with a bipolar vessel sealing device. That's the device there you see in the picture. I love that device. It has many, many uses, especially if you perform vascular surgery quite often. Well worth the money. But the infection rate, according to the study, goes up if you use that device. There's also an increased odds of infection if the procedure is classified as other than clean, and if the indication for amputation was bacterial infection or trauma, more so than neoplasia. Conclusion: use of that device for muscle transection increases odds of infection versus electrocautery and or sharp transection. Dogs with surgical sites that were other than clean or with bacteria infection and or trauma will also increase odds of infection. Introduction: the Center of Disease Control and Prevention defines a surgical site infection as an infection that occurs up to 30 days after a procedure without implants. Which 30 days, I'm surprised. I would think 10 to 14 days because most incisions you expect to heal in that time period, but they use 30 days. Surgical site infections are further characterized as superficial incisional, meaning skin and subcu, or deep incisional, meaning fascia and muscle, and or organ/space infection, which is any operative site other than the incision. At least one of the following criteria must be met to diagnose infection: purulent discharge, organism growth following culture, or clinical signs associated with infection. Here's what's important for surgery boards. The reported incidence of surgical site infection in veterinary medicine is 2.5% for clean procedures, 4.5% for clean contaminated procedures, 5.8% for contaminated procedures, and 18.1% for dirty procedures. Limb amputations are classified as clean, although the surgical rate reported for amputation is 8 to 13%, which is more than you'd expect for a clean surgical infection rate. And like we said, clean is 2.5%. And this is 8 to 13% for amputations. The duration of anesthesia and surgery, age of the patient, surgeon skill level, presence of concurrent endocrinopathy, number of individuals in the operating room, the material used for skin closure, using prophylactic antimicrobials, increased duration of postoperative stay, and placement of a drain are all implicated as influential factors for developing infections in dogs. And a lot of those you can attribute to amputations. A lot of those factors, if not all of them, are commonly seen with amputations. Materials and methods, animals, 2012 to 2020, inclusion criteria were an amputation, either forequarter, coxofemoral disarticulation, or transfemoral. Data collection: hypothermia was defined as any temperature below 98.5 degrees Fahrenheit. Hypotension, less than a mean arterial blood pressure less than 60 millimeters of mercury, or systolic, less than 90 millimeters of mercury. Wounds are classified as clean if an infection was present on the limb, as long as the infection was not at the surgery site. If it was at the surgery site, it was classified other than clean. A subcategory of clean with distant infection was created, which included dogs in which the surgical site was clean, but a distant infection was present. Results: 30 days minimum follow-up required, mean age of dog 7.7 years, mostly spayed females, and then very close second, neutered males. Mixed breed dog was most common at 17%, golden retriever 15%, lab 7%. 9.2% had a preoperative infection either at the surgical site or on the affected limb distal to the site. Dogs with preoperative bacterial infection had a wound classification of clean, 65.2%, or other than clean, 34.8%. based on the location of the infection. Indications for amputation were neoplasia most commonly at 80%, trauma 11%, bacterial infection 3.2%, implant failure 3.2%, and so on. Neoplasia include bone osteosarcoma 66%, soft tissue sarcoma 13.5%, mast cell tumor 4.5%, histiocytic sarcoma 3%. 62.5% underwent four-quarter amputation, 27% coxofemoral distal articulation, and 10.5% transfemoral. The procedures were clean in 95.9% and otherwise than clean 4%. Monopolar electrocautery was used in 64.5%, sharp transection 36.3%, bipolar vessel sealing device 27.4%. Some dogs had more than one used. Perioperative antimicrobials were given in 99.6%. Cefazolin and Clavamox were two of them. Cefazolin and ampicillin, sublactam. 12.1% had other surgical procedures performed concurrently, most commonly mass excision at 60%. 12.5% of dogs developed an infection at the surgical site. Mean time to identifying the infection, 11.2 days. Descriptors include discharge from the surgery site, most commonly at 74.2%. Redness, 16.1%. A culture was used to confirm it in 77.4% of dogs displaying signs of infection. Dogs with bacterial infection as their indication for amputation was more likely to develop an infection than cancer. So 37.5% if the reason why you're amputating is infection versus 9.5% with cancer. If you have trauma, that also increases chance of infection, 47.4% versus 9.5% of those with cancer. Dogs with wound classification other than clean were more likely to have infection, which is 50% compared to 10.9% of dogs that, other than clean was 50%, and then those with clean, 10.9%. Dogs with a wound classification of distant but clean did not have increased risk of infection, or other than clean in classifications, but dogs with other than clean remained more likely to develop infection than those with clean. Dogs with bipolar sealing device was more likely to develop it, 20.6%, versus without using the device at 9.4%. Use of monopolar electrosurgery and sharp transection was not associated with infection. For indication of amputation of cancer, only dogs that had use of a bipolar vessel sealing device were more likely to develop infection at 17% versus 6.8% without using the device. Monopolar electrocautery or sharp dissection was not associated with infection. When evaluating dogs with wound classification of clean, the rate of infection was 10.9%. For clean procedures, dogs that had bipolar vessel sealing device used were more likely to get infection at 18.8% versus 8.1%. Monopolar cautery or sharp dissection did not result in infection. 23.4% had other complications, most often incisional inflammation at 32.8%, seroma at 29.3%. Discussion. In the study reported here, the overall incidence of infection following limb amputation was 12.5%, and it was 10.9% for clean wounds only. Neither duration of anesthesia or surgery affected this. Use of bipolar vessel sealing device increased odds of infection. These are consistent with another study that showed that clean surgical procedures have an 8 to 13% infection rate. Risk factors identified for infection after limb amputation in this study include using a bipolar vessel sealing device, wound classification other than clean, and indication for amputation being infection or trauma. In 2 studies of people, use of bipolar vessel sealing device was not associated with increased odds of infection in thyroid surgery and axillary lymph node dissection. In the present study, use of bipolar vessel sealing device was associated with a 2.5 times increased odds of infection across all procedures, 2.8 times increased odds of infection for cancer only, 2.6 times increased odds for clean cases only. The bipolar vessel sealing device used in the present study assesses tissue impedance to adjust energy output and minimize temperature and carbonization. Monopolar electrosurgery is reported to have a larger zone of lateral thermal spread than bipolar vessel sealing devices, but monopolar electrosurgery was not associated with increased infection. One study evaluated multiple uses for bipolar vessel in an ex vivo model and found that hydrogen peroxide was an effective sterilization method for multiple uses. Although they noted increased tissue adherence to the jaws with repeated use, no other functional consequences were noted with repeated use and sterilization cycles. Procedures that were categorized other than clean, meaning contaminated or dirty, had an 8.2 times increased odds of infection in this study. Dogs that had bacterial infection or trauma for amputation had a 5.7 and 4.5 times increased risk of infection, respectively. Previous studies in human medicine have shown remote infections, including infections localized to the skin, are associated with increased infection rate of surgery, but they were not the case in this study. Prior studies in veterinary medicine have found both generalized dermatitis and dermatitis localized to the surgical site to be risk factors for infection in patients undergoing tibial plateau leveling osteotomy surgery. People have demonstrated that patients experiencing blunt trauma have impaired immunologic function with depression of both cell-mediated and humoral immunity pathways, resulting in an increased risk of infection. In previous study, factors identified as significant for increased odds of infection in dogs undergoing surgery included increased age, increased duration of anesthesia and surgery, intraoperative hypotension. The material used for closure of skin has been debated for infection, with the use of skin staples increasing the odds of infection in one study but decreasing the risk of inflammation in another study. I don't like using skin staples. I think that you get better cosmetic healing and less inflammation and less infection if you use skin sutures, external skin sutures for closure. I don't like skin staples unless I'm in a rush, meaning the patient is unstable during anesthesia and I have to finish the surgery quick. So my only criticism here really is, you want to have more animals involved, of course, but this is a pretty good number. This was 248, not bad. And then the thermal injury being a big factor here. I wish the histopathology characterized how much zone of thermal injury, even the different levels of thermal injury from the biopsies. That'd be interesting to know as well. All right, everybody, see you tomorrow. Thank you.